Hello, everyone. Welcome to this webinar hosted by the Health and Human Rights Institute of the National Center for Civil and Human Rights. This is the second installment of the Health and Human Rights Institute's web series devoted to addressing mental health disparities. Today, we will be discussing states failing mental health parity laws, and we have an engaging presentation planned for you. This virtual series is made possible through the generous donation of the National Black Talk Association for Education and Talent Development. My name is Maya Watson, and I bring you greetings on behalf of the Health and Human Rights Institute. I would like to welcome each of you today, and we hope that you are doing well at this time. Before we begin, we would like to clarify that the thoughts and ideas expressed today are those of each individual. They do not reflect the views of the National Center for Civil and Human Rights, nor any of its agents, employees, or components. We invite our attendees to ask questions through the Q&A link option on Zoom, and then we will pose those questions to our panelists during our question and answer period at the end of this event. Today is the first Monday of Mental Health Awareness Month, and we will be discussing how states can better ensure that health insurers who provide benefits for mental illnesses do it on an equitable basis compared with the coverage provided for physical ailments. To aid us in this discussion, I will introduce you to the facilitator for today, who will then present our panelists. Our facilitator is Helen Robinson. Helen is the Associate Director of Public Policy at the Carter Center. Helen, thank you for joining us today.
Thank you very much, Maya, and I'm very honored to introduce our panel for today's webinar. We are joined by Megan Douglas, Associate Director of Policy for the Kennedy Satcher Center for Mental Health Equity at Morehouse School of Medicine. We are also joined by Jewel Gooding, who is Executive Director of Mental Health America of Georgia. And finally by Benjamin Miller, who is Chief Strategy Officer for Wellbeing Trust, a national foundation dedicated to advancing a vision of a nation where everyone is well in mental, social, and spiritual health. So thank you to all of our panelists, and thank you to everyone who's participating in the webinar today. I'm going to go ahead and start the discussion. And I may call on people on the panel, but hope that everyone will please chime in with their responses. And I wanted to start with Jewel. Jewel, the topic of this webinar is behavioral health parity. And throughout the webinar, we may use the term behavioral health instead of mental health. In case anyone is not familiar, what is behavioral health?
So behavioral health is a term that allows you to look at both mental health as well as substance use or addictive behaviors. So it's a combination, because if you think about it as, how we behave in certain ways, whether it's addiction or whether it's our mental health that may be challenged with mental illnesses. So we try to utilize that term to encompass both of those. So when we talk about that, we're referring to that.
That's right. So it's a more comprehensive way to look
Absolutely.
at it. And Megan, if I can go to you next so that we're level setting, what is parity in behavioral health?
Sure. So parity, and in the context that we are talking about it with regard to health insurance, it really refers to requirements that health insurance plans cover services for mental health and substance use disorder treatments in the same way that they cover services for other medical conditions.
And can you talk a little bit about whether this is required? Does federal law require parity?
So we have a lot of different laws actually that cover parity. The Mental Health Parity and Addiction Equity Act is a federal law that was passed in 2008, and it requires large group insurance plans to provide parity for behavioral health services if they provide those services at all. So it does not mandate that they provide that coverage. But then in 2010 with the Affordable Care Act, that law made a few changes to parity, extending some of those benefits to individual insurance plans and also to Medicaid managed care programs. Then we also have a lot of different state laws. So at this time, pretty much all 50 states have some sort of parity law, and those state laws can do several things as well. So They can supplement the federal law by extending parity requirements to other types of insurance plans. So those that are regulated by the state, like for state employees. They can also provide some more meat than the federal law. So for example, I mentioned that the federal law for large group plans may say that they don't have to provide those those services, but then the state laws may come in and require coverage for some of those services on the plans that they can regulate. And then the last and probably one of the biggest areas that the state laws come in is around enforcement and compliance. So the state laws can require the insurance commissioner or the Medicaid agencies to actually be proactive about enforcement and compliance, which we kind of look at it as the most important part, because a state could have a very strong parity law and not enforce that law, and it doesn't have the impact that it's intended to have, or vice versa. A state may not have a very strong law on the books, but they're doing a lot of different enforcement and compliance activities that would result in better coverage for people in the states.
So it sounds like whether it's through federal law or state law, and whether you have public insurance or private insurance, many of us should be covered by parity protections. And Ben, I'd like to throw it to you next.
Sure.
The word parity is such a technical term.
Yeah.
And so I'd really like us to get started with this webinar by having you break that down a little bit and tell us why is it important to the people who are listening?
Thanks. Thanks for giving me the easy question at the top here. That's a tough one, Helen. You know, I think that when we can talk about issues of health insurance, most people get a little bit confused just at the get-go. It's complicated. It's not easy. Most of us, if we've experienced healthcare or have used our health insurance, have done so reluctantly. The language that's used in this world that we live in is so cumbersome that it makes it really hard to even know what we mean when we say deductible, or that's this type of health plan or that type of health plan. And so for the layperson who doesn't live in Wonkville with some of us, it does get a little bit challenging to understand the terms. Basically, parity, as Megan said so eloquently, it rights a wrong. It does something that we knew we shouldn't have done, but we didn't know any better. Back in the 60s, when we created some of the first mental health benefits, there really wasn't any understanding of what your health insurance should look like that includes mental health and addiction. People didn't know. So they created, these one-off plans that oftentimes treated mental health as very different. And unfortunately, that led us to the scenarios that we're in today. So what is parity for us and why should it matter? Well, if you or a loved one, your neighbor, your family, anybody is trying to find access to mental health services, then parity ultimately should be that thing that protects you. It's got your back. It makes sure that folks are doing what they're supposed to be doing when it comes to your benefits and treating it at the same level as your health insurance, as Megan said. Now, there's three big problems to it, which I think have already been articulated, but I'm just going to say it again because it's why it matters. Number one, it's rarely enforced. So we've got this beautiful law. It's been on the books for some time now, and rarely do we enforce it. Number two, mental health parity doesn't apply to all plans. So for example, if you're only on Medicare, mental health parity doesn't apply to you. So that just makes it another, deeper level of confusion. And number three, most of what we're going to talk about today is parity in law. But I think what most people care about is this parity in principle. How do we make sure the mental health and addiction services are treated the same way as any other health-related services across the board? That means and where it's how it's delivered, how it's financed, not just how it's covered. And I think we'll probably get into that a little bit more today. So thanks for the question.
Thank you. And yes, I have found that whenever I am talking to people, friends, colleagues, family members, you will hear these stories time and time and time again about people struggling to get coverage for behavioral health services that are necessary for people to live their life and function. I was wondering if any of you could share a story that you've heard, possibly, Jewel, do people come to you and talk about the impact that it has on their life when insurance coverage is denied?
Absolutely. So one instant, of course, being in a public health advocacy, we come across many individuals who look at advocacy almost as legality, and it's not. So oftentimes they come to us looking for legal advice and advisement when it comes to accessing their behavioral health services. So for one instance, we did have a mom who was trying to get services for her child who had a now known diagnosis of schizophrenia. And as we know, schizophrenia for children is not quite as often. So it did become kind of a battle between the insurance company and the doctor in recognizing this diagnosis and her being able to access the level of treatment needed in order to manage her symptoms. So when you're talking about psychosis and trying to reduce those hallucinations, when she was trying to get specific medication, she was denied and stating that there wasn't medically necessary. So that's kind of the terminology that's kind of phrased upon with the insurance company. So she had that back and forth battle just trying to get her child some services. And what was the disappointing part in that, the social aspect of that, was that she missed out on school. She missed out on integrating with her friends because she was suffering without any treatment in place. So that's just one instance where she should have received, she was on Medicaid and should have received those services and wasn't given to her, well, she was on Peach Care, sorry, wasn't given the full amount that she needed because she wasn't on that full Medicaid reimbursement.
And that's one of the, I think the cruelest aspects of this topic that we're covering today is that when you're in crisis and you're only trying to do what's right for your loved one, to have an entire system seemingly up against you, it doesn't fill you with just, happiness and joy. It's actually adding a problem on top of a problem, which I think is part of the reason why this webinar today, while it seems like something that's quite nuanced, it might be a little bit down a darker alley of policy work. It's actually something that we all need to be paying attention to. Because the last thing that we want is for us to be in that situation, to be the mom, to be the dad, as Jewel just described in that scenario, and have to fight an insurance company just to get what's best for your kid. That just doesn't, it shouldn't be. In 2020, we should not be having those type of discussions, but yet it's the reality for folks every day. So again, it's why the importance of this topic.
Absolutely.
Wonderful. Thank you both for that. Megan, I've heard you speak very eloquently about how parity is truly about access to treatment. It's again, not a technical thing that doesn't impact people's real lives. Can you talk a little bit more about that?
Sure. Less than 20% of people who need treatment actually receive it. So turning that statistic around on the other side shows that 80% of people who need treatment do not receive it. And there are a lot of reasons behind why someone may not receive treatment. But a lot of it, and in the studies that have identified, have produced those statistics, insurance coverage is often mentioned as the number one reason why someone has not received treatment or sought treatment. These services can be expensive, and the healthcare provider world for mental health is a little bit different than primary care services as well. And a lot of mental health service providers may not accept insurance or may not accept certain types of insurance. So it does get very complicated, but that really is, the more types of plans that provide parity and provide coverage for these services, the more likely that it is for someone to be able to access those services. And I reflecting on what my colleagues, just talked about with why this conversation is so important right now, especially having this conversation in the context of health equity and health disparities. People with mental illness are considered a health disparity population alone, but then this conversation also raises the opportunity to talk about all the intersectionality around mental health disparities and the different, populations that seek treatment differently, receive treatment differently, by race and ethnicity, by geographic location, by sexual orientation and gender identity, or having another disability. This really is an issue that hits everyone. So another, I think, reason that it's really important that we're talking about this and access today in this context.
Yes, and it also seems really urgent to talk about this right now because more and more people may be seeking treatment for behavioral health concerns during this crisis. Dr. Miller, can you follow up on that?
Sure. I mean, you can look at any of the surveys that are coming out. I just saw a piece today that said that the crisis tech supports and the number of folks that are calling in to crisis lines is up 1,000% this month from last month. And a recent study I saw showed that 70% of folks were worried about their physical health, and close to 60% of folks were worried about their mental health. And this was so shocking to me. That shouldn't be shocking. This last point, where 8 out of 10 folks feel that COVID and the coronavirus is going to have a negative impact on their mental health. I mean, right then and there, it's an opportunity to have a very different type of discussion around mental health in this country. And whether we can blame it on stigma as to not wanting to have this conversation before, or other priorities that we just put before mental health, now is the time for us to be talking about this, because the second wave of what comes after the virus is going to be almost as, if not more, more difficult for folks than this first wave. Yes, the virus is real. Yes, it's killing a lot of folks. But all of us that are kind of in isolation, working out of cloudy rooms in our house, it's really challenging for us to think about how we're going to recover from this if we are not paying attention to how we take care of each other. And center to that is how we talk about our mental health. So I think it actually should be the leading story of everybody's newscast at night. Yes, we should be talking about tracing and treating and identifying and all the other public health terms that you hear thrown around COVID. But we should also be talking about how are we doing with this crisis for our mental health. And you don't hear that right now. It's crickets outside, and we should be having that conversation more.
I agree, and I think that this crisis shows more than ever that without behavioral health treatment, people will not be able to, quote unquote, recover from this and return to work and the way life was. And so I think that it is a unique window of opportunity to normalize this conversation about why everyone needs access to behavioral health treatment when they need it. Megan and Jewel, would you like to follow up on that?
Yeah, I mean, definitely with the COVID-19 pandemic impact on employment. We're talking about, and this whole conversation is around insurance coverage, and some of the early projections. This was a report put out by Health Management Associates showing that depending on how high unemployment levels got in Georgia, between 400 and 6,000 more Georgians would become eligible for Medicaid, and almost 1 million Georgians would lose their employer-sponsored insurance. So, we're not talking about small numbers, and even within this context of where people get their insurance, if they don't have insurance, it becomes a lot more complicated to try to navigate these systems. And there really just is not, not enough services available to cover that uninsured gap.
And you also have just families overall that, the levels of trauma in trying to manage some of the traumatic situations they're in, whether they're considered an essential worker, because we're looking at more essential workers in the lower income pool. So they're more likely to have less insurance coverage. And when you think about it, one, that it's always separated, why do we have health insurance and then behavioral health insurance, and not being able to integrate the two of those, that's going to have an impact on a lot of families. You have more domestic violence, you have more abuse with children, you have so many other social determinants that are going to be impacted as a result of unemployment, as a result of lack of school. Where are children going to be trying to integrate back into these communities? This is a bigger push than we have. And even looking at a very strained workforce here in Georgia, identifying what are some flexibilities that have been allowed during the crisis that will continue after we are no longer under this public health emergency.
Can I say one more thing on this one? I just think it's so important what both my colleagues just mentioned here. We've often described COVID as the triple threat against our mental health and well-being. And I think it really speaks to what both of them just said. There's social factors, but then there's big economic factors. When we see unemployment rise at the rates that it is right now, unemployment is a risk factor for suicide. It's a risk factor for drug overdose deaths. It's a risk factor for a lot of things. And when we lose our coverage because it was probably provided by our employer and we do not have health insurance, as Megan said, the likelihood that we're going to just jump up and go seek care because we don't feel good or because we want to talk to somebody is very small, because folks are going to avoid seeking care because they can't afford to pay for the care without insurance. So it's this cyclical pattern that I'm frankly terrified is going to wreak havoc on our communities, and not all communities will be impacted the same. Getting to the core of, I think, today's discussion here, some communities are going to be impacted much worse than others. And we've seen this play out in New York City. And let's just go up north for a second. If you look at the communities that had the highest level of health disparities in New York City, they're the same communities where people are dying more often and prematurely to COVID. The same communities, it's the same bright spots. Well, why is that? It's because those profound social inequities and issues of justice and disparities were there way before this virus landed. And this virus it does not impact us all the same. No matter what some folks may say, it is not an equal offender here. This is something that is impacting disproportionately communities of color, especially communities in those areas that we know have higher level of disparities than many others. And so I just think like this, I've already said this 3 times, but I say it one more time. This is why we as a nation have got to join hands with each other and bring this topic to everyone's attention, because it is not going to go away tomorrow. And when we are talking about this 18 months from now and figuring out, well, what should we have done back on that amazing webinar that we did on May 4th, it's our time to take action.
And I'll just share a study that I and several of my colleagues in the National Center for Primary Care at Morehouse School of Medicine, hopefully this will be coming out today, but we looked at the COVID-19 positive case rates in Georgia and the county level factors associated with it, and found that the higher percent Black population in counties was the only significant factor associated with higher levels of COVID-19. Even when we controlled for things like uninsurance and poverty level. So definitely to Ben's point, very clear, markers for decision making, and where, resources are allocated, and just hoping that our, public health systems, nationally are able to respond to this data coming in. The other thing that came to mind with the access issue was, that we are expanding rapidly the use of things like telemedicine and other, ways to provide services. We just within, our own health system, we have a lot of providers who are providing it for the first time. And so it is, this definitely is moving people to try to find some more innovative solutions to this. Again, insurance is still going to be an issue, and Medicaid and Medicare have changed some of their telemedicine policies as a result of the pandemic. But if, we still have the problem for people who do not have insurance.
Yes, thank you, Megan. And to that point, it sounds like there are many equity issues involved here, but one distinct equity issue is people who have no insurance being unable to get coverage for behavioral health services, period. But then people who have insurance, whether it's public or private, being denied coverage because behavioral health may be treated differently than physical health. And I want to say at the Carter Center, our mental health program works under former First Lady Rosalind Carter, and she has advocated for over 50 years to decrease stigma against people who experience behavioral health issues. So this may be a little bit of a leap for people, but can someone explain, how does insurance reimbursement policy lead to stigma against people?
Well, I think you think about insurance, period, right? Who has access to health insurance? Particularly, there's a huge gap, particularly for Medicaid, for low resource individuals, African-American males or males who are between a certain age gap. They're not going to qualify for Medicaid, but yet they also may not have the funding available to go to the marketplace exchange to be able to receive their insurance in that aspect of it. So most times they just go without it. You don't think about, when you think about behavioral health and mental health in particular, you will find that individuals aren't going to just jump up and say, hey, I have a mental health problem, or, you know, I may have this mental illness, it runs through my family. We're not having those conversations enough to really determine whether our needs are higher or lower in some of those aspects. So most times when you don't have the conversations, you don't get the support. When you look at the delay of treatment from when your initial diagnosis to the time that you're actually receiving that treatment, and then you also look at access barriers in the community. Do you have immediate access to behavioral health services? Is there a brick and mortar in your area? Are you aware of what's in your area in order to access services and supports? And honestly, the reality is most times they don't. And because it doesn't become that crisis, it's only when you're hitting that crisis and you're not able to function fully, do you actually say, hey, where do I start? You know, and how do I get some of that treatment? Because otherwise, historically, we know that no one wants to be perceived as being crazy. So the idea is always going to be that, no, nothing's wrong with me. I can get through this. I've pushed through it. But now we're hitting such a huge crisis, right? That you're not going to be able to have that same level of resilience because you haven't been able to access those services and supports before. But now that it's in your face and now that you're pushing it, you're almost kind of forced into accepting that maybe I need support. So oftentimes you see those gaps. You see where you're accessing health insurance overall. Most times if you can't afford the health insurance in the marketplace, if you don't have it through your employer, or just like Ben was talking about, the deductibles are so high that it's not even worth it. If you have to meet $1,000 deductible, which you probably will never get to if you're a healthy individual, then most times you're just going to say, forget it. It's not worth it. And I'll be fine. And I'll just keep pushing, not realizing the chronic ramifications to your physical health when you don't get the support that you need.
And I think it might be helpful for us to define too what the word stigma even means. And I think, you know, we use it a lot, but the classic definition is basically difference plus deviance. So difference would be an in versus an out, you know, the people that have it versus the people that don't. And then the deviance comes in when you're treated differently because you're in the out. And so if you can track that, it's much better on a dry erase board. I think you get the point here that anytime you're discriminated against based upon some criteria that is different from the dominant, you know, structural party or whatever it might be, social party, social construct, then that's a stigma. And stigma is social at the same time it's structural. And so examples of social stigma is how we talk about it. You know, it's, you know, you're crazy, or that person, you know, they just, even how we describe mental health is oftentimes stigmatizing, but it's social because we reinforce it by treating people different when they tell us that they might be depressed, or they might have had too much to drink every night this week, or whatever it might be. That's the social side of it that we have to address. The structural side comes out through the insurance, comes out through when people show up at a primary care doctor's office and the primary care doc says, you know what, we can't help you here because you're suicidal. We're going to send you to the emergency department. Like that does not send a signal of hope and does not make people feel like mental health is a natural part of the fabric of how we have created a healthcare delivery system. So for most folks, they don't experience that structural side because they don't even get engaged in the, you know, the services to begin with. But most everybody can relate to experiencing it on the social side.
Right. And I think, you know, there's also the, you know, the cultural aspects to this as well as the structural side. We had another recent study come out. We just looked at Medicaid, people that have Medicaid. And so, you know, kind of meaning that they are the same levels, around the same levels of income, have access to the same type of health coverage. And we saw very different outcomes by race and ethnicity with regard to access to the services, but also with regard to what kind of treatment, when people were getting treatment, what kind of treatment, whether they were getting medication or therapy. And, you know, we can only tell so much from doing studies like that. But, you know, a lot of other literature supports that there are different cultural preferences, you know, as to what types of treatment and where people want to seek treatment and what is, you know, convenient or accessible for people to get that treatment.
Yes, and it seems to me that if someone is internalizing some of the social stigma, and then but they get over that and they reach out for help, and then they get turned down for insurance coverage for the treatment that they're seeking, that sends the exact opposite message that we want them to receive, which is that you have a right to receive treatment and you're doing the right thing. So I like thinking about it as the social and the structural and how they are interacting with each other. So we are all based here in Georgia, other than Ben, and we want to turn now to how is Georgia doing on enforcement of mental health parity. And I know that Megan has done some significant research in this area. So tell us a little bit more about where we stand now and where you think Georgia could be going to improve parity.
Sure. So we released the technical report that you're referring to, where we assessed all of the state laws at a national level in the end of 2018. So when that report came out, Georgia got a D for the strength of our parity law. Georgia did pretty good with how we define behavioral health. We have a pretty inclusive definition of both mental illness and substance use disorders in our statute. We don't have anything in our statute about enforcement and compliance. So that was one of the areas that, brought us down to a D. So, we talked a little bit earlier about that enforcement and compliance and who does what. So we have the insurance commissioner, who in Georgia has authority to enforce the private insurance market. And then we have the Department of Community Health, which regulates the Medicaid program. And we know that, both of those agencies are working to try to, understand what their role is in the parity enforcement conversation. But I think, it comes down to resources and capacity within both of those state agencies to actually do this on a robust level. And that's kind of the, kind of conclusion that we have come to as far as what those agencies are able and willing to do. And a lot of it comes back to, that capacity piece.
It's probably fair to say, I think we mentioned this earlier, that without enforcement, the laws can just be words on paper. And there is a process if an individual is denied coverage and they believe that it was against, it was a parity violation. They can file a complaint. They can file a complaint with their insurance company. They can actually fill out an online complaint form with the Department of Insurance. But that will always be just drip, drip, drip. And what we really need is systematic enforcement, proactive enforcement by state agencies. And I know other states struggle with this. There are others that are doing a little bit better. And maybe there are some best practices that Georgia could look to as well.
Yeah, there's a lot of tremendous examples out there of states that have built on what we would think of as model legislation or a gold standard for parity enforcement and compliance. And they've done, it's almost like they're playing this competitive game where each state wants to one up the other. And so they add a little bit more to sweeten it. For example, Illinois used to be the gold standard, but then I'm partial to this because I lived in Colorado for so long, but Colorado really did up the game and make it a little bit better. So this is no longer an issue of what's the language to use and how to do it. It becomes the issue of courage, and will leaders and state leaders be willing to stand up and fight for something that's going to benefit, frankly, all of us in different ways. And that to me is going to be our challenge. Now, what does that take? And I think we'll probably get to this, but I don't need to tell this audience because I'm sure you understand this requires all of us to come together with a singular message of what we want, to apply those social movement principles to mental health, and to, in some ways, in the nicest way possible, grab your torches and your pitchforks and let's go storm the castle, because things do have to change. Without us constantly rallying around something that we believe needs to be done different, it will be status quo. And I know we've talked about this in other groups and other times, but there's a natural evolution that is inevitable for change. Some of it will be good, some of it will be okay, mediocre. What we want is something that's much more substantive in its effect. And having robust parity within Georgia, or frankly, other states that have not done what our gold standard states have done, would be a game changer for many families.
And I do think we have an opportunity, right? Georgia is, at a point where right now we're looking at health insurance on many different levels and looking at that access points and recognizing where our workforce kind of stands, and even putting in the forefront that, yes, there are going to be some challenges moving forward, post-COVID that we need to really address, particularly from a behavioral health standpoint. So I do think, with the information that's being kind of developed, looking at the Department of Insurance kind of temporarily suspending health insurance, for a while during the crisis. So I feel like this is an opportunity to recognize that, yes, we want to make sure that people's coverage can continue so they can access services, but it's also a leeway into a conversation of how can we continue this, because it's going to be a while to rebound from some of this. And as we're continuing it, are we making sure that behavioral health is, one, being included in plans, that people recognize that this isn't not an automatic option for you, that you do have to select, you do want behavioral health services, and being able to engage in these types of conversations so that more people can recognize where they do have a voice. Recognizing if you look at your insurance, because again, just like Ben was talking about earlier, insurance can be a little humdrum, and it's really overcomplicated and cumbersome, and trying to really dissect it. But it's also a really good way to just ask yourself, access right now. And this is where some of the starting points can happen. And when you recognize you don't have access, then now is the time to actually start having these conversations with your legislators, being able to engage with them and say, this is not just the next 2 to 3 months that I'm going to have to deal with this. This might be a couple of years. And I want to know that someone is fighting for me to make sure that there is mental health parity enforcement and compliance for whether it's public or private, and that even people recognize it. So it isn't kind of a consumer, you have to figure it out, but there is a partnership between the two that more people are able to access behavioral health services.
Thank you, Jewel. And I completely agree with you that there is momentum and that there's a window of opportunity that we can seize around this topic. In the Georgia General Assembly, there has been a lot of discussion around insurance adequacy, whether the term network adequacy, whether people can actually find the type of doctor that they need covered in network by their insurance. There's been a lot of discussion around surprise billing, which I think is going to just explode with the COVID crisis as well. So I think the legislature is primed to sort of take on this really tough topic of insurance regulation. We also have a new state commission, the Behavioral Health Reform and Innovation Commission, which is meeting to try to figure out what are the next steps so that Georgia can become best in the country on some of these issues, and advocates can feed into that. And of course, there's been ongoing advocacy around making sure that more people have health insurance through Medicaid expansion here in our state. And I want to pick back up for the people watching a couple of things that Megan and Jewel said that have happened temporarily because of the public health crisis. One is a loosening of restrictions on telehealth and telebehavioral health, which is absolutely critical during this time when people are not supposed to be going to an actual physical office to seek services. And then also Jewel mentioned that the Department of Insurance suspended temporarily, at least through the end of this month, the cancellation of health insurance for failure to pay your premiums. Those types of things are absolutely life-saving and critical. And I think that one thing that people watching this could do is talk to policymakers about extending those a little longer. As Ben said earlier, the behavioral health issues are going to be the second wave. And so we can't just hurriedly say we don't need telehealth anymore. we can go back to the way we did things before, because there's going to be quite a long runway of needs when it comes to behavioral health.
And I think some of that comes down to right now, if you look at how our country has invested dollars in mental health, especially in light of this virus, it's appalling. We've put $425 million into mental health out of multi-trillion dollars that have gone out the door. And if you want to just put that in perspective, $425 million to SAMHSA was 0.56% of what the airline industry received and 0.2% of what all healthcare providers and hospitals received. So it's frankly, the ongoing marginalization of mental health is appalling and should scare all of us that this is not, I mean, I shared an article earlier, I put it in the chat box for those of you, but it actually is on the front page of the Washington Post around the importance of addressing mental health. We're seeing in our caregivers, so the folks that are on the front lines doing the delivery, you're seeing them come home. We saw that high profile physician that ran in the emergency department in New York die by suicide. These stories will not go away. And folks like us that make projections on data and tell stories that are really scary, they're scary data. And it's because in many ways that we just continue to not address this issue. So Helen, to your point, this webinar couldn't be more timely. I think that all communities do need to come together in service to asking for something bigger and better. And it might begin with your local officials. Are you all talking about how mental health is impacting our community in South Georgia? It might be at a state level, going to another elected official and say, what are we going to do with this, this rush of folks that are going to be enrolled in Medicaid when it doesn't look like we're doing a great job enforcing parity, blah, blah, blah. And it might be at a federal level. Okay, Congress, you've invested, budget dust in mental health, do something real. And that's what I think it's going to take. There is a level of investment here that goes alongside parity enforcement, that goes alongside delivery change, that goes alongside culture. And all of that stuff addressed at the same time will make a difference.
Yes, excellent. And would you actually like to follow up by talking a little bit about the family focused toolkit that you have been working on?
Sure, I'll do that really quickly. So in response to some of the amazing work that my colleague Megan Douglas has done, we realized that there was a lot of folks in our communities that didn't understand what their benefits were when it came to mental health parity. And so while we can write about it and talk about it, it's one thing for us to do it. It's another thing for a family or someone who's gone through it to write a guide that speaks to other families on how they can get through it themselves. So we're actively working with a family that has experienced some pretty egregious parity violations and who is writing a guide that will be useful for other families. So when they begin their journey to try and interface with the mental health system, that here's some ideas or suggestions on what they could do. It will be basic, and we think it'll be really helpful for a lot of folks because there are so many individuals out there who simply don't even know where to start if they're denied of their benefit, if they're denied a claim. And we want this to be kind of a first step for that. So we're definitely happy to share. Don't have a URL or anything fancy that you can tweet out right now, but we will have something that we can share in the next few weeks.
That sounds great. And I think that it's such an important point to make that when a family is denied coverage for behavioral health treatment, oftentimes they are in the middle of a crisis. And to turn from trying to cope with that to I have to figure out what is covered in my health insurance plan can be daunting. So I think it's really important work to think about someone who's actually been through that process, explaining it to other family members as well.
That's right.
And I just to carry on that point, because it really is important, and we're having this conversation and it still sounds like the burden of navigating this system falls on the consumer. And unfortunately that is in a lot of ways what the reality is. But that is also a way that policymakers can come in, and that's another place that some states are being really innovative about consumer transparency and what benefits they have, and making sure that the networks that are listed on their health plans, or that providers are updating what insurance plans they accept, and a lot of room again to try to take some of that barrier off directly off of consumers, and and provide some of these resources at a system level.
Absolutely. So as Maya mentioned when we first kicked off this webinar, May is Mental Health Awareness Month. It is why we tried to wear green today. My green is so dark, I'm not sure if you can tell it's green, but we are wearing green. Please look up Mental Health Awareness Month. Think about ways that you can learn more about some of the topics that we were just discussing. I think Maya will be able to share some resources that we may all be putting together to help you learn more about this critical issue. But also, just to hammer home one more time, talk to your policymakers. I'm talking to the participants listening. Talk to your policymakers, talk to your elected officials about ensuring that behavioral health, for mental health support and substance abuse support, are included in the state and national recovery efforts in this current public health crisis. It really is not an option. This issue needs to be elevated and prioritized at this time, unlike in any other. And again, that need is going to continue for quite a while, following any potential end to the physical health aspect of this crisis. That was kind of my last pitch as facilitator. I would like to hear from each of you if you would like to share one final thought with the people who are watching today, and then we will turn it over to Maya.
I think that was a good sum up, and the call to action was clear.
Thank you.
And I do agree that just being mindful of how mental health challenges can kind of just unfold all, throughout the month. So even though we might be steady right now, still being a strong and advocacy and recognizing that we do have to take a stand with this. And even if it's just for prevention purposes, right? We go to the doctor to get checkups, the same way when we just want to make sure everything's moving. So doing that checkup from the neck up is still just as important, and making sure that we can still have free access to do that without having to come out of pocket, without looking at it as a extra burden for our families overall. So that one, it just improves our economic piece of it, right? It's not just about the touch feel good, right? Because that's kind of what people think about when they think about mental health. It's also about our economy. When people don't feel good, they don't do very well. So then they're less likely to go out and to more likely maintain employment, to stay out incarceration. These factors are going to play into the importance of why we advocate for this, why we have these conversations, and why your mental health is important. It is to reduce rates of suicide. It's the 10th leading cause of death in Georgia. So we have to really kind of eliminate that number altogether, so that we recognize that people can be here and not feel the way that they feel all the time.
Yeah, I can't add much to what you all have said. I think that mental health is all of us. And our ability to feel comfortable addressing the topic, as taboo and stigmatized as it's been, is one of the most substantial ways that we can change the culture around it. Be comfortable bringing it up, be comfortable talking about it, learn the right language to use, read an article or two on the importance of it. The rest will fall in line. This is truly about changing the culture, and the only way to do that is by using it in our language, and using language that reflects empathy, understanding, and support. I mean, my goodness, if we can't do that right now, then our nation's in a world of hurt, because we're all lonely and isolated, and we get together through Zoom and webinars and things like this, but it's different. And it's time for us to recognize that the way that some of us might feel now is the way that many of us have felt for a long time. And to acknowledge that, to embrace it, and to not be afraid when someone admits that they might feel a little bit more sad than usual. It's an okay thing.
Absolutely. Well, we definitely want to thank each of our panelists today. You all have been awesome in unpacking this very heavy topic of mental health parity. I think it's a complicated concept to many people, but you all were very clear, and we appreciate each of your contributions today. So Megan, Helen, Jewel, Ben, thank you so much on behalf of the National Center for Civil and Human Rights, for participating today. We invite all of our audience to continue to submit questions through our Q&A link on Zoom. We already have a few submissions. Asante Farquharson, has two questions. His first is, good afternoon, what policies currently in Georgia should be a starting point for reform in generating equity and access to behavioral health care? So that question goes out to any panelists that would like to answer it.
Sure.
So I'm not sure.
Oh, go ahead.
Well, I'm speaking of it more of what workforces we have, right? And Helen talked about one of those behavioral health reform and innovation commission that was legislated in the past session, not this current session, that gives us an opportunity to do just that, where they are recognizing and looking at a broader view of behavioral health services overall and access points. So this is where we can start by getting connected to our legislative offices and recognizing who those chair folks are, who are a part of those committees, and that these are the conversations that we can start inserting as they're talking about hospital beds and short-term care, as they're talking about accessing children's services. I think all of those are things that you can be connected to, that you could start learning about different policies. But I'll have Megan can continue because I know she has the policy aspect of it.
Well, I think, I mean, those are all very, very good points that we can start with. And I think, you know, moral of the story being there are a lot of points that we can start with, and there is a lot of foundation already within the state. So a lot of opportunities to just build on that. We do have the current law on the books, so we can, you know, potentially amend and strengthen that language that's currently in the law, or we need to focus on implementing even what's currently in the law and enforcing and even understanding how insurance plans are complying with the language of the law.
You're muted, Maya.
Thank you, Jewel and Megan. Our next question from Asante says, what would be some suggestions in the training of healthcare workers to address the structural stigma that currently exists?
I'll give a couple of quick examples of that. First of all, there are becoming more trainings, and I can't speak specifically to Georgia. I'm sure my colleagues can, but there are specific trainings that are being offered up to healthcare providers on the front lines. We've participated in a 2-year collaborative over the last 2 years on how to address mental health more effectively in the emergency department, which is a place where a lot of individuals experiencing psychiatric emergencies show up, and they're met with sit here and wait, or they're treated as if, you know, they're unsafe. There's a lot of things that are just pretty egregious that happen in emergency departments, and individuals experiencing some type of psychiatric distress and emergencies oftentimes get treated pretty poorly. So we provided a 2-year training to major health systems on what that looks like. But honestly, I think one of the best things that a system, a clinic could do, which is less a training and more a change in style and direction for delivery, is to figure out how you can get a mental health clinician to come in and work with you. This is happening all over the country more often than not. And the delivery and financing systems sometimes make this really, really, really hard. But there's a lot of amazing mental health clinicians that are just sitting out there wanting to figure out a way that they can better integrate themselves into a different type of setting. So if you're in the medical profession and you're working in a primary care practice, as an example, figure out who's around you. Go shake hands, take some donuts over or something healthier, and just get to know them and say, listen, you know, I work down the street. We get a lot of folks that have mental health and addiction needs. How could we work together? To me, that's the best training because it's experiential. It's frontline. You see it with your own eyes, what it looks like when mental health is addressed in the right way. And it does what we've needed to do for some time, which is to create more of a team-centric approach to care, something that really builds all the solutions off the patient's back, because the patient is the one who we're trying to serve in the first place.
And there are models here in Georgia, like for instance, if you can't access a mental health clinician, we have certified peer specialists that can be integrated, that have become a Medicaid billable service that a lot of practitioners could utilize the same level of expertise, but maybe have a deeper relationship with consumers. Because again, you know, think about that stigma, right? You don't want to go and talk to a shrink or someone who's going to make you feel, you know, that you're in your feelings, but talking with someone who may be experiencing the same thing that you may experience or have experienced, that's what peer support is about, right? It's really connecting to another individual, whether that's for families, whether that's for caregivers, or whether that's for individuals experience a behavioral health challenge in themselves. Being able to connect in that aspect would be a really good starting point, where Georgia already has kind of the lead in the nation in providing certified peer specialists, but just crossing it over into our medical practice, we're looking at a system of care approach, right? That's really what we're thinking about, recovery-oriented system of care, where we're really integrating all different parties to support our whole health, not just our body and our brain, but it's together. Really looking at it from that aspect is a really good starting point as well.
Thank you, Ben and Jewel. We have a comment from Marcy Thrash. She said, with the sharp increase in telehealth using phones, no-shows for psychiatry around the country have dropped from around 50% to nearly 0%. Did that elicit a response from any of our panelists? Would anyone like to speak to that?
I just want to say first that I was speaking with someone recently too who works with youth, and there was some anecdotal data that shows that some young people are enjoying telehealth counseling and participating in it more fully now that they are not physically able to see their therapist or counselor in person. And I think when you hear things like that, it really does make you think, is there a way to continue the positive aspects of this beyond the immediate crisis that we are currently in?
I mean, healthcare is one of the few things that we still pay for that we have to wait before we get something from it. I mean, anybody, people right now probably watching this webinar are buying something off a website that's going to be here tomorrow. I mean, we've all become just acculturated, used to a new way of providing, you know, instant gratification or instant delivery of a product. Healthcare doesn't work that way, especially for mental health. We get told we have to wait. One study that came out last year showed that 96 million Americans had to wait over a week to get access to a mental health provider. And that's actually pretty good. In some communities, it could be upwards of 3 to 6 months. And so that's horrifying. So of course they're happy when you can just hop on a phone and talk to someone in your PJs at 4 o'clock in the afternoon without having to take off work and worry about what's happening with your kids and how you're going to cook dinner 2 hours later. It's easier because it's the way that it should be. We should have brought healthcare to people a long time ago and stopped relying so much on these antiquated notions that healthcare's got to come to us. I mean, the people wanting healthcare have to come to us. It's just not the way that it could be. And I think this crisis is showing us that we can probably do it a little bit different and maybe even better.
Particularly when you also think
Absolutely.
about all of the different barriers and access to behavioral health care.
Yeah.
Transportation is usually the biggest reasons why most folks, particularly in rural areas, can't access behavioral health care. You even think about it from the VA when they have to show up to that appointment, and when they don't make that appointment, then that appointment is canceled. And then now you have to figure out again, all over again, how to get back to that appointment. You know, so naturally it fits in with what is needed for the community, but that doesn't mean to say that should be the only model, right? It should just be a part of an expanded model of how to access healthcare.
Yep, and historically, you know, telemedicine has been available to people who could pay out of pocket, or, you know, those that have private insurance and more resources. So as with any other innovation, it's just important that we make sure that it's accessible to everyone. And, you know, that ties into the health equity theme as well. So I hope that policymakers and are paying attention to that as they think about, you know, what changes have happened and how we roll back into normal life.
Absolutely. I think we have time for one more question, and our last question will be from Samantha. But let me also encourage our attendees to look at the chat box and look at the Q&A box, because very valuable references have been put there by our attendees and by our panelists. Rennie Sloan, and I see Red Smith also gave a helpful website. So please refer to the chat box and the Q&A box. Samantha asks, just like telehealth regulations are loosening, are there any other regulations we should advocate to be more loose in order to increase access? Jewel, I think you talked about the lack of access.
Yeah, I think there are lots of different regulations we can think about, particularly that's been in legislation over the few years of who can actually bill for services, what licensures do we have in place, and how sometimes the licensures is vastly different, particularly if you're coming from a different state and trying to gain licensure here in Georgia. It's overly complicated for those individuals who are wanting to practice here but don't necessarily meet the same measures. That is very kind of what Ben was speaking to, is antiquated in regards to being able to access services and supports. So I think that's one things that we can look at in loosening that, or not loosening, because of course we want licensed folks to be a part of this, but making it less complicated so that you can expand the workforce, or even thinking about having, I think we're doing like cross-state services can be provided. So we're not even, we recognize you have a license in a state, but we're allowing you to practice in the state because we need the help, we need the support. And that should be a little bit more of an ongoing practice, because we're surrounded by so many different states that if we're all struggling, then we need to be able to pull it all together from our neighboring states as well too.
Absolutely. Thank you, Jewel. We are now at the end of our hour. So we want to thank all of you for joining us today. We want to encourage you to come back 2 weeks from now to discuss mental illness among young people in marginalized communities. And then on June 1st, we have a discussion geared toward trauma-informed care relating to gender-based and intersectionality-based violence. And on June 15th, we'll discuss human rights, HIV, AIDS, and mental health. We hope you will join us for these subsequent discussions, and we want to thank all of you for joining us today. We hope that you all will be well. Thank you so much to our panelists and attendees.
Thank you.
Thank you.
Thank you.